Okay, some disclosures you see up there. The most important ones are all the way on the right. I like to do mountain biking and photography and some, product innovation. So the CurvaFix implant is FDA approved. It's been on the market and being used. More than 100 cases have been done, so it's really a startup, but doing cases. The question is, why actually have a new pelvis implant? I mean, what's the big deal? So the reality is that the pelvis has intraosseous corridors that are curved, and most studies that are done out there looking at corridors really think about a straight screw going through a curved path. And I'll show you what I mean by that in a second. Remember that larger implant diameters also increase the stability of any intraosseous fixation. So if you think about a nail in the tibia or in the femur, you increase the diameter by 1 millimeter, and then you increase the stiffness by a third order magnitude at least, depending on the diameter. This implant, at least, has been shown to decrease pain immediately and allows patients to mobilize pretty quickly. Over 50% of these patients are elderly, older than 65. And there is a study that has already been done called the RESTORE study, which I'll talk about in a minute. And then there's a new study, RESTORE PME, if anybody's interested, but it's basically a study looking at consecutive cases that is currently underway. So this is kind of the patient experience. It's more than 115 patients now. I think it's probably more like 130 something. 71 of them, or 62%, are high velocity trauma, fragility fractures, and 32%. Revision of those 115 only occurred in 3, meaning that these were revision surgeries for other implants that were performed. Oncology patient 2 and implants about 150 in those 115 patients. More than 65-year-old patients, we're looking at 58%. And then they're used all over the pelvis, posterior pelvis, anterior pelvis, acetabular column implants, so anterior posterior column, et cetera. And then iliac wing, like LC2 type implants. So why is this compelling? In my mind, it's compelling because, as I said, the pelvis has corridors that are curved. You have the anterior column, posterior column, LC2 or iliac wing, and sacral corridors. Screws are straight. Screws are generally used like intramedullary nails. They can compress fractures, which a curved implant really can't. And they cannot fill the inner walls when used in a curved corridor. I'll show you what I mean by that in a second. So they can't be as large as a curved implant, especially if it's flexible and then gets locked. So you have something that looks like that. That's like an anterior column screw. And you can see that that's the size of that implant, and a much bigger implant, if it's curved, is able to fit in that corridor. And that's been borne out by at least clinical experience. This is a classic view of the cross-sectional anatomy and corridors into the S1 body. What you see here is essentially, this is the L5 nerve root. Really, it's L5, L4, and obturator nerves are sitting there. And then you don't want to be in front of this red line or behind this red line. That's your corridor. And traditionally, you're going to put a screw in that looks like that, or a transsacral screw that looks like that. Really, we all wish, though, that we had a screw that looked like that, which is much bigger, much more stable, and is able to get around the corner. And this is an example down, I'll show you this case in a minute. It's a dysmorphic patient with a dysmorphic upper sacral segment where you have to have a curved implant if you're going to S1. Usually S2 is a big corridor. You can put something straight in there. But S1, if you want to capture that, you have to have a curved implant. So the reason why I'm excited about, one of the reasons why I'm excited about this is because we did a study looking at dysmorphic patients with dysmorphic pelvis fractures, SI screw placement. This is a multi-center study. It was a randomized study looking at fluoroscopy navigation, and then 3D navigation. And the main outcomes were looked at with post-op CT measurements of sacral wall penetration, meaning you put a screw in, and then if it hits the wall, it goes through the wall. That means that that's not where you want it to be, right? You want it to be inside the corridor. And the percent of agreement between 6 observer looking at all the CTs was 69%, which is really good. Kappa 30.38, P less than 0.05. So with fluoroscopy, missed screws, 11.9% non-dysmorphic group, and then 28% in dysmorphic group. So much higher rate of missed screws in patients that have an unusual anatomy of the upper sacral segment, which is what's expected. So, the bony anatomy, this is just a sawbones, but bony anatomy, as you can see, these curved corridors exist in the pelvis. And if you look at how this implant actually works, you basically put a guide wire in, followed by a reamer, and then there's a steerable ball tip guide wire that you can move along. It's hard to see, but I'll show you guys cases that you can move along within the corridors and actually bounces off the inner part of the corridors under fluoroscopy. And then you can curve it so it stays within the correct trajectory within that corridor. And you put it in, you twist it, you tap it in a little bit, twist it, tap it in a little bit. And then after that, you basically ream with a reamer. And then you put an exchange, it's a ball tip, so you can ream over it, and if there's a problem, you can pull it out. And then you exchange it for a exchange tube for a smooth guide wire, which is what you see there, and then you put the implant in. Pretty straightforward. And then after you put this implant in, you can actually lock it. So there's a little screwdriver you put in the back, and you just twist it, lock it, and then you unfasten it, and that's the end of it. So pretty straightforward. It's a few more steps than putting a screw in, but it's pretty easy to use, actually. So Restore, we did a clinical study looking at this. These were just the first 25 patients, essentially, looking at the safety and technical feasibility. The idea was basically just to fix the pelvis and acetabulum. It was a prospective multi-center single-arm non-randomized study. And the primary objective were basically to evaluate the safety and technical feasibility of the CurvaFix implant. Inclusion criteria was almost everybody over the age of 18 and less than 70 years old. These are all the sites. So in San Jose, California, UT Houston, et cetera, as you see up there. They had 25 patients with 27 implants placed. Again, this is just an initial clinical trial, right? So this is just to make sure this thing actually works and the instruments work, et cetera. And 81% of the patient ambulated at discharge. So how many of your pelvis, fracture patient actually ambulated at discharge? It's pretty good. 100% were ambulated 3 months. 96% maintained implant stability, which means that nothing moved. And the complications, there was one implant that backed out of the posterior wall column screw, which was actually double reamed. So there was like an error in the procedure, one of the first implants. And two, the instruments had to be changed. And so there was a problem with the instruments, but it didn't affect fixation. And all that stuff has been fixed since that time. So here's a couple example of cases, and then I'll give it to our other speakers. Mildly displaced anterior column with posterior hemitransverse acetabular fracture. It's hard to see it, but on the CT you can see it, like right here, right there. So you could decide to leave it alone or to do something with it. If you let them walk on it right away, you can give them that option. That's what we did. So here's how it looks. Anterior column screw, essentially initial reaming, which you can see here. So that's initial reaming after putting guide wire in. The steerable ball tip guide wire is then tapped in into the corridor, and you can see how it's nice and curved. You can curve it in there, and then reamer, followed by exchange, and then putting the screw over it. And you can see how the screw just follows the corridor. So it kind of bounces off the inner walls and follows the corridor, and always have a posterior column screw there. Another one, this is a 70-year-old male with jujitsu master who was moving a deer from the road and was hit by a car, right? So a good Samaritan gets hit by a car. He's got this pelvis fracture, and I'll show you what that means in a second, and he's a polytrauma type patient. He's got a sacral fracture, essentially. You see that's kind of through and through over here, as well as the anterior part of his pelvis is also broken. Same idea here. His S1 was very dysmorphic, so we went actually into S2, and you can see the screw going in the same way as we talked about before, just following the trajectory. And you see the same thing here and there. He's 1 year post-op now, really just complaining of pain in this plate. That's all he's complaining of, no back pain, no problem with his posterior fixation. And then the last one, this is a 24-year-old male who has an APC type 3 pubis symphysis dislocation, and the posterior part of his pelvis is actually fractured, not open. So it's kind of an unusual pattern where the posterior ring is not open through the SI joint, but really there's a fracture in posterior and proximal displacement of this left hemipelvis, as well as distal radius fracture, which we're not going to talk about. And he's got a sacral upper segment, which is a little bit dysmorphic. And the whole idea here is, if you can imagine what the screw actually sees, so you're inside the tunnel trying to get to where you're supposed to be getting to, and it looks like something like this. It's basically like being on a train track and trying to get around a corner. That's kind of what it looks like. And if you're the screw actually looking at your trajectory through the corridor, it actually looks like this, right? That's what it actually looks like, because these things aren't really straight. So if you want to fill that whole curved channel or the whole curved corridor, the way you'd have to do it is with something that's curved, not straight. So in this particular patient, you saw, I'll go back here just for a second so you can see. So he had, open pubis here, and as we said, he's got this fractured sacrum in the back here. And you can tell, from the pre-op CT that he's got dysmorphism in the upper segment, because the trajectory to place a screw would be basically, from posterior to anterior, pretty steep trajectory here. And then you can also see on the coronals that basically you have these, you can't find a corridor where you actually have a straight shot. This is S2 down here. So the idea is, as I said, filling something that's curved. And we know that the bone is much better up at S1 than S2, right? Anybody who's done pelvis fracture, try to compress through S2, you'll see that the bone there is not very good. So here the idea was we fix the front and then screw the back. So compress the front with a couple of clamps. I like to put sometimes 2 of these in order to really get compression. Fix the superior ramus here, and then I double plated them because I was scared that it would not work with one plate because of all that force. And then and I'll show you the intraop CT, but the next thing we did is actually put a straight screw in S2 that was a compression screw, because, as I said, you cannot compress through using a curved implant. You have to do something else to get compression. And then we essentially, the entry point over a guide wire. And the idea here is that this entry point doesn't have to be perfect. It has to be close to perfect, but it doesn't have to be perfect. It takes a little bit less time to find it. And the reason why that is because you have a curved implant that's going to go into the corridor where it needs to go. So it's not like a straight shot. It's easier to get it in there. So this is the steerable ball tip guide wire that's tapped in. That's the outlet view and the inlet view, and then the reamer goes over it, followed by an exchange tube, which you can hardly see because but there's an exchange tube here. And then we put the implant in, essentially over the guide wire, lock it, and then just disengage the inserter, and then you have a locked implant that's sitting there. It's pretty straightforward. That's what it looks like with intraop verification. This is our S2 screw that's going through the S2 corridor. Here's the CurvaFix implant that's going through S1. And again, you can see that because there's dysmorphism, you can't see this whole corridor on this view. You can see it on this view, but you can't really see it on this view. And the fracture is, I think, pretty close to being reduced. So that's what it looks like post-op. There's 3 months. Our X-ray tech was very excited about doing outlet view. And then last one, 24-year-old female right sacral fracture, another dysmorphic patient. I'll show you the CT. So she's got this very small corridor. If we want to put a screw in there, we can go to S2, but our S2 is also pretty small. This is how we want to put that screw in. And again, the same idea, cove over the top. The interesting thing is, and I've learned a lot actually from this implant, is that the corridor sometimes isn't what you think on the inlet view, because as you see here, essentially the screw goes in and then it goes a little bit posterior. See that? So her corridor actually isn't on the inlet view, isn't straight or from back to front here. It's basically coming in, it could have been back here to back there. So back, front, back. And you'll see that on this is the real outlet view here. You can see how it comes in and then it goes posterior. And I was kind of worried because I didn't know, I was worried where this was. So I just stopped it short of the SI joint because I was kind of worried about it. But here's how it looks holding that fracture 6 months post-op.